Hi, I'm Lizzie Woods. I'm a community palliative medicine consultant in the northeast of England in Gateshead. I've been a consultant for just over 2 years.
And during that time and for the year prior to you becoming a consultant, you actively participated in the public health approach to palliative care. So, what are the things that you do which are different from your training and your routine clinical duties as a palliative care physician?
So for the last probably 15 months, I've had 3 hours a week of charitably funded time to work on developing a public health approach to palliative care in Gateshead. Initially, we got this by applying for a repurposed hospice UK grant through the ICB, and that was to set up a project called Compassionate Gateshead as a pilot in Gateshead and see if we could start to look at some forms of community development and also how we might work into some of the strategy around public health palliative care. The other part of that funding was for a project manager 3 to 4 days a week who would really lead the project. That came to the end of its first year in April, and the funding for the project manager has been continued for at least another year by the local public health team. And then I had 3 hours a week of my time for ongoing clinical leadership into the Compassionate Gateshead funded through our hospital charities.
What are the things that you are spending your time doing under the role of Compassionate Gateshead?
We've kind of tried to split it so that we divide the work between myself and the project manager. The initial things we did was a consultation across Gateshead with just the general public and then also professionals, so anyone who works with people who would experience death, caring, dying and bereavement in either a personal or a professional way. And then the first year of work was really driven by the results of that survey. So we heard that children and young people feel that they fall between gaps in services and they don't really have a voice, and that it's very difficult around workplaces and coming back into work after a time off or trying to navigate caring and working responsibilities. So they have formed the main strategy of what we do, in that we've split into a couple of work streams that we have time on children and young people, and through that have been linking with the local authority and the educational psychology team, and really being the people who just ask the questions. So going to a meeting with them and saying, what do you do around death awareness, death literacy, grief literacy in schools? What could we support you with? And sort of being the catalyst of conversations that people then take away and will develop. Similar things in workplaces. And then alongside that, we have run 2 big events. So the first was a launch event aimed at more of the professional and the strategic people who would be interested, where we had a vision launch of the concept in November 2025. And then over Valentine's Day, we ran a festival of compassion for the whole month of February, where we talked about all different aspects of death, loss, caring. We had the local media come. We asked for anyone who might want to put on an event that month to get in touch with us. And then we coordinated the programme of events and have used that to kind of increase awareness of what we're doing, find new people that would be interested to partner with us and work alongside us. And it's kind of formed the next year's worth of work.
And how have you managed to persuade your public health team and your ICB to support you in what you're doing?
It's not easy. And I think the difficulty we have working within the NHS and with the ICB is that we know there's not really much money and there isn't any more money coming. I think we're told that over and over again. So it's thinking of the key things which really everyone can identify with. For public health, as they say it, it's a 1 in 1 statistic, so everyone will die. One of the really helpful things we had was that our Director of Public Health, she does an annual report, and in the first year of the project, it was on shining a light on deaths from drugs, alcohol, and suicide. And as part of her recommendation from that was that Gateshead should become a compassionate place to try and support the or minimize the ripple effects that we see from these deaths. And we know that in Gateshead, we are one of the areas with the highest deprivation ratings. And there's a lot of work we can do around inequality. So I think having the endorsement in that report was really helpful. And then it paved the way for us to work alongside public health to be embedded in the health and wellbeing strategy. So when I looked at that, it was all about being born well and kind of growing and developing well, but there was nothing in it about dying well. So they had a little bit on aging and nothing on dying. And were really receptive when we went to them and just said, you're missing the final chapter. And actually they went, oh yeah, we really are. And then worked with us to embed that. And that enabled us to go and speak at the Health and Wellbeing Board as they were presenting the health and wellbeing strategy to raise the awareness of compassionate Gateshead. I think one of the other key things is making it personable. So as part of the work we've done, we've been working alongside Winston's Wish as a national childhood bereavement charity. And the key sort of stat which they shared with us in one of our early meetings is that 1 in 29 children will experience the loss of a parent or sibling in the first 18 years of life. And I think when you hear that, whether you're a parent, a grandparent, and you stand outside school and you're in the line to pick up your children, you think that's 1 in this class. And it's when you can bring that level of detail home that it becomes really real. And I think when you can talk to people and they see why it's important, and it's actually been things like that far more than hospital waiting times or reducing pressure on A&E, it's really the stats like it's 1 in 29 children and this really matters. And how do we make it better? Because every child has a family around them. And if we kind of look after this whole family group, could we start to improve outcomes further down the line? The other key thing we've got in Gateshead is it was an early area to use social prescribers or community link workers. And kind of alongside the work we've done with Compassionate Gateshead, we've had several successful, initially charitable applications and now funded more through the ICB and the local authority of embedding a community link worker within the palliative care team to really look at how do we assess the holistic needs of a whole family so that we make sure everyone's on the right benefits. We look at their housing, we see how we support them through employment. What do we do with the dog? What matters and how do we get them to play golf? And the other key thing that people have really engaged with when we've shared at the various events we've done is patient stories. So the work that the link worker has done, getting someone who'd played golf all their life to go and play golf again for a final time. And those have been the things that have engaged people.
Has that changed the nature of the multidisciplinary team meetings in terms of the discussions that you have about people?
Yeah, in that it takes it far more away from just the clinical approach. But one of the things that she's done is she's had various different organizations gifting things like weeks away for families at the coast for free. So as well as you're thinking, what are their needs? She'll be there saying, oh, and have they got children or grandchildren? Would they like a week away at a caravan? What are their interests? Actually, I know someone who there's an art class that would be great for this person. Perhaps I could go and meet them. And she's quite proactive at suggesting where she could come and help and thinking of things that we wouldn't have previously considered in our MDT.
And in terms of your own satisfaction with the work that you do, has this added to what you do?
Definitely. And I think I feel really lucky to have those 3 hours a week of non-clinical time, because what we don't get in any of our job plans now really is that clinical leadership time. But just having the opportunity to go and I've just come now from a meeting with one of the leads of the public health teams, thinking about how do we start to embed the work that we're doing through Compassionate Gateshead into what's already existing in the public health. So planning a meeting to meet with the 3 leads for sort of children and young people's well-being, and someone else who looks at their integration of the new relationships into the primary school curriculum. And that's completely outside of what we were trained for. But it is nice to have that separation from clinical work to think about the bigger picture of what we do. And you meet really interesting people.
So my name's Suzanne MacArthur. My background, I'm an occupational therapist by profession, but left the NHS about 12 years ago and moved into the hospice sector, where I worked in Marie Curie for about 8 years, 8, 9 years, as a manager and in community engagement, and then moved to Birmingham Hospice as head of community development and partnerships, where I worked there for 2 years, working with the diverse communities of Birmingham, looking at how, as a hospice, we could engage better with those communities and meet their needs in a more culturally sensitive and appropriate way. So, having been a manager within the hospice setting, I was really clear, or I could just see it, that actually as a hospice provider, palliative care service provider, we thought we're the expert, and that communities should fit in to our service, that we knew what the communities needed, and yeah, they should fit in. And it wasn't surprising that actually the majority of people that were accessing our services were white middle class. And the opportunity for me to go out and actually meet and consult with those communities about what good end of life care looked like for them and what good grief support looked like for them actually really opened my eyes, that actually we weren't doing it right at all. There was a totally different focus on what was important to that community that wasn't what we were delivering as palliative care providers. We were missing some real golden nuggets. So, you know, our palliative care services were all focused on symptom control, looking at, you know, obviously supporting that patient and their family through that journey, but in the way that we thought that they needed it. You know, we'd got our systems in place, people that we would refer them to based upon what we thought was best. And what I found was actually that's not what they wanted. There were things that weren't even on our radar.
My name's Colette Hawkins, and I'm an academic consultant in palliative medicine based in the northeast of England. And I worked as a clinical consultant in Durham for many years. I have an academic portfolio now, largely because I am very interested in gaps in how we deliver care in the NHS, and the needs that people have that we're possibly not meeting as we should be. So I've spoken to people who have been through in caring roles or cared for people that they've looked after, who have developed such a wisdom from their own experience, and often quite hard experience, where they've had to battle to get services and advocate for somebody that they're looking after against services who put up a lot of barriers. But because they've come through that, they have a tremendous amount of knowledge that they are desperate to share with other people because they know that's a difficult experience. And one of them even described the army of carers. You know, there are thousands of us, she said. We've learned this through often quite difficult experience, and we've got this wealth of knowledge. We want that to be used. And speaking for myself, I think that I very much had a clinical focus. That was what I was comfortable with. And I really didn't understand the struggles that people had beyond the illness that I was treating. And I was quite naive, really, in terms of how much life is turned upside down by a serious illness and how many people that then impacts. I was not particularly in tune with the impact on people looking after the person who's ill. But in running Roots to Rights research, we've had quite a lot of conversations with members of the public, both people who are ill themselves and people who support other people who are ill. And it's really lifted the lid on how the breadth and the impact of some of these non-clinical issues that people face, that we just aren't engaging with in specialist palliative care circles. And that's certainly been my experience. communities offer something that palliative care services, by and large, are not offering, and to some extent, perhaps don't have the capacity to offer. And it makes no sense not to use knowledge and local wisdom that is there for the taking. And these are people who want to be sharing what they've learned. These are people who have the life experience that walking through that, it puts you in such a powerful position to support other people. It makes no sense not to capitalize on that. It's just missing a huge part of need. And if especially palliative care services don't offer that, there is a massive gap. So we have to, which communities are filling. If we're working independently of each other, it just doesn't join up.